Yes, I guess I will get started with introducing you. Let me switch off that slide first. Um, Hello everybody and welcome to the Women's Global Health Institute public talk on perinatal depression. I'm Ulrike Dudak and I'm the Associate Director of the Women's Global Health Institute. I'm very honored to introduce our speaker for today's event, Dr. Christina Deligianides. Dr. Deligianides is Associate Professor of Psychiatry and Obstetrics and Gynecology at the Zucker School of Medicine at Hofstra Northwell and the Feinstein Institute for Medical Research. She also is the Director of Women's Behavioral Health at Zucker Hillside Hospital at Northwell Health. As a recipient of predoctoral intramural research training awards, she received training in molecular neuroendocrinology at the NIH and additional research trainings at the National Institute of Mental Health throughout her early career. Since then, Dr. Deligianides has become a well-known leader in the field of perinatal depression and in novel therapeutics research. Her research program includes a focus in psychoneuroendocrinology, particularly neurosteroids and hormones, and neuroimaging in women's behavioral health. She has published extensively and has received numerous awards for her research. In particular, I'm proud to say that Dr. Deligianides has an NIH-funded collaboration with Purdue, and she's also collaborating with neuroradiologists at IU School of Medicine. And at this point, I also want to welcome our audience from IU School of Medicine today. To the audience, a general comment, you may enter questions into the Q&A box throughout the talk. We will address all of these questions at the end of the presentation, where you can also still put your questions in at that point. Christina, thank you so much for giving us a presentation today about your research entitled Neuroactive Steroids and the Development of Novel Therapeutics in Perinatal Depression.
Thank you so much for the invitation. I'm going to go ahead and share my content. Okay. Can you just confirm that you have a nice full screen view there?
Yes.
Wonderful. Okay. Welcome to our presentation today. As noted, I'm going to talk to you about our work in neuroactive steroids and a bit about perinatal depression and how our translational research is helping to identify potential targets for novel therapeutics in this significant clinical disorder in women. I'll start with disclosures. I will discuss a non-FDA approved investigational medication. My grant funding is listed here. The studies and research findings that I will discuss today will mainly come from NIH-supported research, but the novel therapeutics research is supported by Sage Therapeutics. This is our overview for this afternoon. I'm going to start out by talking just generally about reproductive mood disorders in women, and then focus the presentation today on perinatal depression as an example of the investigations in an example of a reproductive mood disorder in women. I'll talk about the pathogenesis of perinatal depression, and in particular, how neuroactive steroids interact with brain neurochemistry and the brain's connectivity, network connectivity. Then I'll transition to how some of this work has led to the development of the neuroactive steroid brexanolone and the investigational medication zuranolone for the treatment of perinatal depression. There'll be plenty of time for questions and answers at the end. So I want to start off, really what brought me to this research is that there, for decades, has been a documented sex difference in the prevalence of depressive disorders in women compared to men across the reproductive lifespan. And so we know that estimated lifetime prevalence rates do vary across cultures. However, we do see a reproducible preponderance of depression that's consistently reported in women. Typically, these prevalence rates are 2 to 3 times that found in men. And the increased time of risk is between the periods of menarche and menopause. And so, in particular, to the different phases across that time frame, around the menstrual cycle, approximately 13 to 19% of reproductive aged women report clinically significant premenstrual mood disturbances every month. and about a quarter experience significant perinatal mood symptoms around that reproductive event. And then 45 to 68% of women experience clinically significant mood symptoms around the perimenopausal transition. So if we're to try to look at why women are at higher risk of developing depressive disorders, especially between menarche and menopause, one obvious wants to start to look at the reproductive endocrine system. And so the research suggests at current that there's a differential response in the stress steroid system, so the hypothalamic pituitary adrenal stress system. So that includes corticosteroids and neurosteroids, which I'm going to discuss later, and the GABA A complex, as well as a differential epigenetic and genetic risk in serotonergic and GABA signaling, and that there are interactions between these. And then they act as moderators or mediators between changes that are occurring across these reproductive phases. So either across the menstrual cycle, across the reproductive steroid change of pregnancy and delivery, or the reproductive hormone changes in the perimenopausal period. And that those interactions, those disruptions in those normal interactions between those systems manifest themselves as clinical mood and cognitive and physiological changes that we see in reproductive mood disorders. And so I'll tell you a bit more about perinatal depression. I want you to have a good clinical understanding of the disorder, the impact on mothers and children, and so that we can understand the impact of the disease and then why treatment is so important. Approximately 12% of women giving birth suffer from perinatal depression. That's a clinical depressive episode. And there are numerous professional organizations that recommend screening for depression in pregnancy and the postpartum period. There are international recommendations, and then each professional organization clinically, whether it's psychiatry or OBGYN, pediatrics, family medicine, all have their recommendations for screening as well. So it is recognized that screening is critically important. Unfortunately, despite these recommendations, only about a third of perinatal women with depression are identified in clinical settings. And so it means the vast majority of women are just not identified as having the disease. Of the 30% that are identified in clinical setting, only half of those women actually receive some sort of treatment, whether it be a psychotherapy or a medication intervention. And of those, only half of those women receive what we consider adequate clinical treatment. So are they taking an adequate dose of the medication for an optimal duration, or same with psychotherapy? Are they meeting with the psychotherapist often enough and over the right amount of time? And so given that, it's not surprising that only half of those women actually achieve remission. So 3% achieving remission, meaning that the treatment was successful and that they have no residual symptoms of depression. And so why we have to treat depression is for many, many reasons. And this last bullet point, unfortunately, this statistic has been stable for decades, is that maternal suicide is the leading cause of direct maternal mortality in that first postpartum year, with 1 in 7 deaths due to maternal suicide. So again, you're going to find many reasons why we need to intervene in women who are pregnant and after they deliver. And so part of the challenges are with screening. Part of it is recognizing the clinical disorder. It does have a heterogeneous clinical presentation. And so what I have listed here is the diagnosis that psychiatrists use clinically. And so this is from our diagnostic manual. And it is an episode of major depression. It's a clinical depressive disorder, as you would diagnose in men and women at other times of their life. But this in particular has peripartum onset, meaning the symptoms have to have onset in pregnancy or within 4 weeks of delivery. And so you see the symptoms here. We have to include at least 5 of the following symptoms. 1, which has to be depressed mood or loss of interest or pleasure, again, in pregnancy or after delivery. And you would think that it would look strikingly the same as depression in other times of a person's life or in men. And what we're finding is that it really has a variable presentation. So often the presenting symptom is anxiety. When a woman does approach her healthcare provider and says, I'm not feeling myself, she's usually reporting the anxiety or feeling overwhelmed component rather than feeling depressed. But there is depressed mood, there are crying episodes. Definitely the woman reports that she has loss of interest and pleasure. They don't look forward to things. She's not looking forward to her baby shower. She's not looking forward to the birth of her baby. She may regret that she's pregnant. She's not looking forward to getting ready for the baby or any milestones in her life. Also for the appetite, we see a significant, not just that women aren't eating, but that they report food has no taste. In severe cases, they have to force themselves to eat even a single small meal a day. This can lead to poor gestational weight gain and have ramifications for the baby's weight at birth and growth in utero. The sleep disturbance we see, we've done a bit of sleep work, and the sleep architecture is abnormal, both in the initial sleep phases of initiation of sleep, so falling asleep is disturbed, but also maintaining sleep is also disturbed in women with perinatal depression. Women feel exhausted, they feel slowed down, they are impacted. So they lack motivation to do things. They're exhausted. They're not looking forward to things. And so this impacts their activities of daily living, showering daily or brushing their teeth daily. So women who come to me for our studies are not showering. They're not brushing their teeth. They're putting all the effort in taking care of the baby to make sure that baby's clean, make sure that baby's fed, make sure that baby's cared for, but they're not able to take care of any of their self-care. This leads to excessive guilt that they're a bad mother, and can lead to feelings that their family would just be better off without them. Here's, a good example where you just look at the colors and don't worry about any of the axes or any of the labels. So this is a figure from data that we published in Lancet Psychiatry a couple years ago, and really just shows the point that perinatal depression can really present differently across the perinatal period. And so on the x-axis, you're just looking at different time periods from first, second, third trimester, and then early and a little bit later after delivery. And so the colors just correspond to different clusters of symptoms that women can have. And based on that slide that I showed you. And if the symptoms were stable, if you had the same level of insomnia or anxiety or loss of interest or depressed mood, you'd expect that these, the light green would be the same width all the way across, the dark blue they would all be identical if this symptomatology was stable, but it's not, right? And so you can see that there are points where in first trimester, in the dark blue, you really have a severe depressed mood that's present and also severe anxiety. But if you look at the fourth bar, the postpartum bar, you see more of loss of interest and anxiety. So the symptoms are a little bit different across this time period. So that can also contribute to the difficulty in diagnosis. So why this is so important is that it's impacting mom, it's impacting health outcomes for the woman, and it's also going to impact fetal and infant neurodevelopment. And so I even took 3 slides and could give a 2-hour session presentation on the impact of untreated perinatal depression. These are just a few of a very deep literature evidence base of the associations between untreated perinatal depression and adverse health outcomes for mother. And so these are important to understand, especially as we talk to women about medication options in pregnancy. They also, for them to be fully informed, have to understand the potential risks of not treating the depression as well. I'll say more about that later. A fascinating area of research occurring both preclinically and in clinical populations is this kind of transgenerational transmission of neuropsychiatric risk for the development of psychiatric illnesses later in life. And so this harkens back to the developmental origins of health and disease hypothesis that proposes that the maternal environment during pregnancy induces changes in early development and influences adult offspring health and chronic disease risk. And so for this particular situation with antenatal depression or antenatal anxiety, which is occurring in pregnancy, that hypothesis is that prenatal stress is influencing prenatal developmental trajectories via placental glucocorticoid and serotonergic mechanisms. And there's an amazing literature in this area on how the placenta function as an endocrine organ and is responsible for how stress is transmitted to the fetus in utero. And then, and again, the bullet points on here are just a sampling of things, but that there are sex-dependent differences on the trajectories. And so that male and female fetuses are differentially affected by prenatal stress and have different trajectories as they mature. My last slide on this, because I know I'm really focusing on it because it's just so important. If we don't take care of pregnant mothers, now we're doing a disservice to women, but also it's impacting their baby's infant brain development. And so the goal is not to read the tiny, tiny font in front of you, but rather to show you there's some really elegant neuroimaging studies looking at both structural and functional connectivity that are looking at neonates from as early as day 6 post-uterine life, all the way up to early, as an infant or early childhood and then beyond. And unfortunately showing that the developmental trajectories of these children are different compared to infants born to euthymic and healthy mothers without mood disorders. So the good news is that we do have effective treatments. And so we have psychotherapies, and this is really indicated as single therapy for mild unipolar perinatal depression. So again, this talk isn't about bipolar disorder, which is a different psychiatric disease that women can have, but for unipolar perinatal depression. The bulk of the evidence base is for interpersonal and cognitive behavioral therapies. And then the research literature is now developing or reporting the development of kind of subpopulation psychotherapy. So for women with sleep disorders, cognitive behavioral therapy interventions for insomnia are super subspecialized for those women. And then for those women maybe with a history of trauma or recent trauma, there are trauma-based psychotherapies that are also used. But for women with more moderate severe unipolar depression, so for the women that I would treat in my practice, they're typically moderate to very severe unipolar depression. As a physician, I use pharmacotherapies, and the bulk of that work is with antidepressants. And so these are standard of care SSRIs, SNRIs, or tricyclic medications for some women. And there's an evidence base in postpartum women, because these are randomized clinical control trials weren't done during pregnancy, were done after delivery for perinatal depression. So we do have the evidence base that the medications can be efficacious for most, but not all women. And then if they're utilized in pregnancy, because the depressive episode can either have onset in pregnancy or after delivery, if the disease occurs during pregnancy, there are different risk factors, right, of prescribing that medication to a pregnant mother. And so we take great efforts and to educate each individual mother on the potential risks, benefits, and alternatives to any of the treatments that she is going to have as a choice for her. And so again, this could be and has been a 2 or 3 hour seminar on how to prescribe and approach the pharmacotherapy treatment for perinatal depression. So this is a very succinct slide at a very high level, but the types of things that we discuss with women are around the potential for fetal malformation risk. I have to say there's been so much work in this area now as compared to many other therapeutics in medicine, that right now we're looking at a small absolute risk increase for potential birth defects or heart defects in particular. And, you know, the absolute risk for these are in the range of 1 in 5,000, 1 in 8,000. So they're not super common. They're a little bit more rare. The other bucket I would put, you know, our conversations include the potential for adverse birth outcomes. And so here, things like, is there a risk for preterm birth or for low birth weight? This one's a tough one to disentangle because the women are depressed, and I showed you that there are correlations between these and untreated depression. And so is it the untreated depression, or is it, you know, the antidepressant medication? So the studies have been a bit mixed on that. But one thing that we do see, and occurs in 30% of women, or for their infants, in women who have taken antidepressants, again, serotonergic SSRIs, SNRIs, tricyclics, in especially late pregnancy, 30% of neonates will develop postnatal adaptation syndrome. And so this is where they can have irritability, changes in tone, abnormal crying, tremor, some respiratory distress, hypoglycemia, a constellation of symptoms that can last for a couple of days or a few weeks, and then it's transient. It does go away. There's also in the literature, what we talk about with women is a much more rare possibility of persistent pulmonary hypertension of the newborn. And so this is a problem with the lungs and the heart transitioning to their sort of extrafetal or extrauterine needs. And so it occurs soon after birth. And this has a high morbidity rate of 10 to 20% mortality rather, and the infants can present with cyanosis or respiratory distress. So the rates here are, you know, about 2 in 1,000 in the general population. There are many risk factors: obesity, C-section, a variety of risk factors that are related with this disease. And then about 2.9 to 3.5 in 1,000 is associated with late gestation SSRI use. And so for pregnancy, it's, as you can see, a very complex discussion. After delivery, for the therapeutics that we're using during perhaps lactation, if mom is breastfeeding, typically a single, you know, antidepressant, again, SSRI, SNRI, medication should not discourage women from breastfeeding. The overwhelming benefits of breastfeeding really do outweigh the risks of these medications for unipolar depression and anxiety. And so while we have some tools, we can do better, and we have to do better for these women and for their infants. And so I want to give you a quick kind of dive into the science of where we're looking for novel therapeutics going forward in perinatal depression. So I want to start with you know, really trying to get a gestalt. It's not just one pathway, right, that leads to the development of major depression. And so what we do know is that perinatal depression is really characterized by an abnormal response to normal reproductive steroid hormone changes, right? So the hormone levels are high, estrogen and progesterone are high in gestation, and then they drop drastically after delivery. But also an abnormal reaction to the normal stress steroid hormone mechanism. So this is more about the hypothalamic pituitary adrenal axis. And so there's this interaction of things that are happening and that predispose women for ultimately developing a major depressive episode, either when steroid levels are high in pregnancy or after they've dropped in the postpartum. And I'm going to tell you more detail. But really, you know, at the higher level, we know that things like environmental stress, adverse childhood events, domestic violence, early trauma, all have epigenetic effects on a variety of systems in the brain. But in particular for perinatal depression, there's evidence of changes in the serotonergic and GABAergic signaling systems. And then we have a lot of data on the hypothalamic pituitary adrenal, the stress axis, especially preclinically. It's just been so valuable to try to translate to clinical studies and clinical work, is that normally in pregnancy, the body dampens down its response to stress. That's in normal pregnancy. But we know in these perinatal women that develop depression, they're unable to dampen the HPA axis. It just runs wild. And so you have this inability to dampen the HPA or stress axis. At the same time, you have the hormones rising and coming down again. And so ultimately, the changes that are occurring and predisposing women to developing this reproductive mood disorder are affecting the brain circuit. And that's where we've chosen to focus some of our research, to look at the neurochemistry that's going to really modulate the circuitry of the brain, and then to look at how these sex steroids are interacting with brain chemistry and brain circuitry. So I'll start with telling you about neuroactive steroids. There's a very deep literature since the 70s, since they were coined, on neuroactive steroids and all of the effects that they can have on the CNS. Simply, there are metabolites of progesterone. So everyone's familiar with the hormone progesterone. As you can see in the figure on the right, these neuroactive steroids are made in the brain. They're also made by the ovary, and they're made by the adrenal glands as well. In the brain, they can serve as transcription factors, they can regulate gene expression, and they can interact with receptors. And so here you see in the figure on the right that many neuroactive steroids can interact with and potentiate the GABA-A receptor. And they're positive allosteric modulators of the GABA-A receptor. While other neurosteroids like estradiol are modulators of the glutamate receptor. So they're glutamatergic modulators. We're going to focus our discussion on GABAergic ones today. And what's fascinating from the preclinical research is that these neuroactive steroids really control the GABA-glutamate balance in the stress circuit, which I told you is abnormal in these women with perinatal depression. And we know that in normal pregnancy, in rodents at least, the preclinical literature tells us that these neuroactive steroid levels, that again are high and then drop, have significant changes on GABA and glutamate in the brain, in the CNS during the pregnancy and post-period times. And so there's changes in these receptor levels, where they're located, how many there are, and also just changes in concentrations of GABA and glutamate in the brain. And so I know that several of the audience members will have a real in-depth understanding of neuroimaging, and while others may have less in-depth understanding. So I do want to take a higher level look and provide further detail for those who are interested. Our methods are located in the lower left-hand corner of the slide. But really, what I want to talk about is how the brain consists of several networks. They work together at rest and or while doing tasks. And, these networks are modulated by GABA and glutamate. And I just told you with the previous slide that the neuroactive steroids are modulating that balance. And so they're modulating connectivity in both men and women, but differently in women because the neuroactive steroids, the concentrations are changing, right, across the menstrual cycle, across pregnancy and menopause. And so, we use fMRI and resting state functional connectivity to examine these systems. It's a real powerful method that we're able to measure changes in blood flow or changes in bold signal. And we use this as a way of understanding which parts of the brain are active. And then at rest, this is called resting state connectivity. What we're really looking for, and you can see in this beautiful figure on the right in the different colors, is that this shows that different areas of the brain are actually the bold signal or the blood flow changes are changing in the same way. They're synchronous changes. And that's how we know that one part of the brain is talking with the other, because they're synchronized and they're working together. And so again, we have many networks, and the network that we investigated is the dorsal default mode network. It's a network that's very active when we're really quiescent, we're just resting, we're maybe introspective thinking, but awake. And so the other modality that we use is proton magnetic resonance spectroscopy, or MRS. And that's a technique that gives us a lot of information based on the properties of molecules, and this one's based on protons. And so we use a technique that kind of excites these protons and changes them, and it makes them move around or resonate. And based on each molecule, depending on how many hydrogen ions it has and where they're located, they resonate in different frequencies. And so because of that, each molecule has a little signature. And so here on the right, you can see I literally took a camera of the spectra off of the scanner during a scan. So this is just sort of the post-processing of the scanner and not of our MRS experts, but you can see that we can measure concentrations of, here is a concentration of GABA by understanding measuring the concentration of the curve. And so the more GABA that's located in our region of interest, we decide that we wanted to look here in the prefrontal cortex. We have a region of interest here. We can measure the concentration of that neurochemical in that part of the brain. And then we can see how it's contributing to the connectivity, because I told you that that both are important for connectivity. So I'll take you through a couple of just a couple of our research findings, and then I'm going to switch to the therapeutics. So we started off, and we published that women with perinatal depression, first of all, have different plasma profiles of these neurosteroids compared to healthy perinatal women. And so just all the boxes in blue that are squared off in blue, those are at higher concentrations in women with perinatal depression than perinatal women with no symptoms. And what we found is that there's even a different profile that with a history of depression, it's kind of a marker. We can see that that's associated with increased deoxycorticosterone and tetrahydrodeoxycorticosterone. These are all GABA positive allosteric modulators at different sites of the brain. And so we're starting to see about that altered, neuroactive steroid environment in these women who are developing illness. And so then we wanted to see, well, these are peripheral levels. We know that they do cross into the CNS based on blood studies and CNS studies. These are all peripheral blood because I didn't want to do lumbar puncture on our pregnant or postpartum women to get CSF. What we did then was to see, is there any relationship between what we're finding in the periphery to connectivity? How's the brain functioning? And so here we published our finding where we took an approach to look at circuits. We did a circuit level sort of investigation. It was an independent component analysis of network connectivity and postpartum depressed women versus healthy. And then we saw that this the component that pulled out was the default mode network. Again, this is that network that's very active when the women are at rest, and has been linked to depression when it's hyper connected, or if there's greater connectivity of this network. It's been associated with the symptom of kind of anxious or depressive rumination, that women can't get unstuck from kind of their depressive thoughts. And that's what we're seeing in postpartum depression. And that network had greater connectivity to this area of the dorsal medial prefrontal cortex. That particular area of the superfrontal gyrus is really related to self-referential processing, conflict monitoring, and attentional control. So a lot of things important that if there's increased connectivity, you can imagine that could manifest in the signs and symptoms of depression. And then we said, is there any relation to that connectivity to depression severity? And we saw that in the lower left panel, where it was strongly correlated connectivity to the depression scale score, the total score. And then we saw that the higher the connectivity, the higher the levels of allopregnanolone as well in the blood. So we found those correlations as well. So we were really interested in the spectroscopy, right? So my hypothesis is that we're going to have lower levels of GABA in the prefrontal cortex and also the occipital cortex based on what we've seen in major depressive disorder. We didn't see that. So we looked a little further. We said, okay, concentrations are one thing, but those who do imaging and do multimodal imaging, I recognize, and I'm not an MR physicist or a trained imager, that it's really important to dive deeper. How are the neurochemicals actually contributing to the circuitry and the EI balance. And so when we did that, when we looked at that level, that's where we found a divergence in our findings, and really led to the current R01 grant that we're working on. And so although we didn't see just concentration differences, and I think the field really needs to move away from just concentration differences too, we need to integrate our understanding that really the relationship between GABA and resting state connectivity changed depending on disease state when we looked at the relationship of GABA and the default mode network. And so we found that there was a negative relationship. So the lower the GABA, the higher that distorted connectivity was in the DMN. And there was no relationship. That relationship was absent in healthy postpartum women. So again, that led to really where we are with our current NIMH-funded R01. We really need to look at the glutamatergic steroids. We need to look at other circuits. We need to understand the relationships between the steroids and the circuits and this chemistry, and really use, to the full power, we need to integrate these modalities instead of, publishing one manuscript on connectivity, one manuscript on the spectroscopy. We're not going to fully understand such a complex system without bringing together these investigations. And the goal of this is to try to understand, is there potentially a target here that we could further develop for a therapeutic? And so, our NIH-funded work, which is everything you've seen so far, really made a very natural, dovetail for me to collaborate with industry and to, be a PI on studies of synthetic neuroactive steroids as potential therapeutics. And so I'll talk to you very briefly about the published work on brexanolone, which is FDA approved, and also the non-FDA approved. It's not approved by any regulatory agency. It's investigational only, of zuranolone. And so here are the two compounds. Again, brexanolone is exogenous allopregnanolone. So everything I told you about allo that the body makes, this is a synthetic version of that. And it's a GABA PAM with the chemical structure here, that's allo. And zuranolone, it's a synthetic analog. So you can see the similar chemical structure, but then you see an additional ring. And we believe that it's that additional ring that allows it to have oral bioavailability and once daily dosing, because the brexanolone is a 60-hour peripheral IV infusion. And so that, could be a limitation for women who can't, get care in, kind of a hospital-like setting. And so here are these are published studies of the brexanolone trials. These are in adult women with major depression, moderate to severe symptoms. This was an RCT, and they were randomized either to 2 doses of brexanolone or placebo. Again, a 60-hour IV infusion in the peripheral vein. And then they were discharged at hour 72 and followed for 30 days. Here you see on the y-axis the change from baseline in the depression severity score. And then on the x-axis is time in days. Now, normal, the usual standard of care antidepressant trials, these would be in weeks because it takes a while to see effects. These are in days. And so you can see that there's a rapid drop even before day 3 because it's at hour 60. And that was the primary endpoint for this study, where you saw a significant reduction in the depression scale compared to placebo. And then you see that improvement in depression is retained even though they only got the 60 hours and they didn't get anything out to day 30. Response and remission rates. So this is, in psychiatry, we'd like to use something that is, are they 100% better? Are they 50% more better? Instead of just a raw score, how much better is the patient? And so here at hour 60, you can see that over 50% of the women clinically didn't have depression anymore. And so that's pretty amazing, 60 hours and half of the women no longer had clinical depression. And for those who had a response, that's 50% or better based on that same depression scale score. That was about 75%. There are adverse events with any medication. And for this study, we saw, as you can see on the left, dizziness, presyncope, vertigo, and dry mouth. There is a black box warning for excessive sedation and sudden loss of consciousness. That the sedation and somnolence that required a dose interruption, like pausing the pump or stopping the pump or reducing the dose, occurred in 5% of brexanolone treated. For the loss of consciousness or altered state of consciousness, the FDA noted that there were some pump failures in some of the trial sites. And so it's believed that those were linked to the pump failures where they got a higher dose than they should have. But regardless, we have a safety protocol through a REMS so that only certain facilities are certified to deliver brexanolone as a therapeutic for postpartum depression. But all of the patients that did have these events recovered with just turning off the pump and letting the mom wake up, because they typically, in those cases, they fell asleep. So this was the zuranolone now. This is non-FDA. This is the investigational. So remember that. And again, same types of patients were enrolled in this study for severe depression. And here you see that they're randomized to either 30 milligrams of the zuranolone or placebo. But the big difference here is that it's a 14-day course of the neuroactive steroid, and it's dosed once a day at home. So this was not in a hospital or clinical research setting. Then the primary endpoint was at day 15, and the women were followed through day 45. So again, it was just a 14-day course, and then they didn't receive any of the zuranolone through day 45. Here you see a really similar curve, and the X and Y axis are the same as what I said before. So the Y is that change from baseline in their total depression scale score. And on the X axis is time in days. And so again, the primary endpoint was at day 15, where you can see statistically significant difference and clinically significant difference in depressive symptoms versus placebo. You can go back as early as day 3 and start to see that separation from placebo and zuranolone. And then again, the medication was stopped, right, at day 14. It was the last day. And all the way through 45, they did not receive zuranolone. But you see that they still continue to show benefit in reduction of depressive symptoms. The response and remission rates, again, somewhat similar. So response was over 70%, and remission rate, I think, was about 45% at day 15. So that at the end of treatment. For the side effect profile, similar proportion, had side effects or treatment emergent effects during the trial. The main ones here were, again, somnolence, headache, dizziness, upper respiratory tract infection, diarrhea, and sedation. There was no loss of consciousness that has been observed with this compound thus far. So in conclusion, our work is really aimed at, trying to understand better the pathophysiology of perinatal depression so that we can identify novel targets for new interventions. Our work really needs to also examine really the biological underpinnings of how antenatal depression differs from postnatal depression, because you can imagine the steroid states are so different. And so, within those key players, what's driving the difference between the onset during a high steroid state versus a low steroid state? And so that's something that I'm dedicated to understanding and figuring out. The other, thing that we want to do is understand why we have such phenotypic variation and such heterogeneity in the presentation of the illness. So we're doing a variety of studies, both at sort of like understanding pathophysiology, but then also looking at potential therapeutics. So my research center works very closely with a very large, robust clinical center. Zucker Hillside Hospital is part of Northwell Health. It's the 9th largest health system in the country and the largest health system in New York State. So we have the pleasure of serving millions of New Yorkers. And it's such a diverse and beautiful community. And so we're here to serve women, especially in the perinatal period. And we do a lot of training too. So we have a lot of training programs, for our medical school, for our residencies and fellowships, and because we know that we need to train our future clinicians and investigators in this important area. So I'll close with just a thank you to our current funders and our collaborators, especially our collaborators at IU and Purdue. And I think we have a good amount of time, pretty good for question and answer. Should I switch off the share screen or leave it? What do you think?
As you want, but I think it would be nice to see you in big, so why don't you just switch it off after a while?
Sure.
Thank you so very much. This was a very engaging and definitely passionate talk.
Yes.
Thank you very much again. We do have one question already in the Q&A box, and I would encourage the audience to put in their other questions also into the Q&A box right now. So I will read them to you, and so so let's ask. First question is by Antonia Susnia, who is asking that this might affect. She's asking whether the menstrual cycle might actually affect MRS data. So you have talked a lot about your MRS exams and GABA and so on, and whether or not when scanning female subjects we should actually take care of this, or whether this could be a confounder.
Yes. So I almost preach this. So absolutely, the menstrual cycle matters, and there's data out there, and I'm not going to remember the first author, by Neil Epperson. She's at Colorado now, but this data I think was when she was at Yale. She studied across the menstrual cycle. She studied the impact of tobacco, the menstrual cycle, and sex differences in GABA MRS. I believe this was still all OCC. I think it was all occipital cortex. And it may have been on a 1.5T that she was using at the time. But she showed a beautiful divergence of the GABA concentrations across the menstrual cycle in women without any premenstrual symptoms. So didn't have any mood symptoms. And then for women with premenstrual dysphoric disorder, a type of reproductive mood disorder that occurs monthly in women, they just showed a complete divergence of the GABA concentrations from the follicular to the luteal phase. So we actually in our studies, and it's astonishing now that, you know, I'm finding more and more, I mean, as I review papers and grants, I call this out to investigators because first of all, menses matter, right? So we're not little men, and you know, we're different, and we have decades of data of understanding how these steroids affect GABA and glutamate in the brain. Why wouldn't you want to take that control? So, if you don't do it, and you don't, you just scan men and women in spectroscopy studies, you're adding variance. And if you do a women's study and you don't obey the menstrual cycle or acknowledge it, you're also adding so much variance, and up to 15 to 18% variance. And as you know, sometimes that will just wipe away what you're trying to look at, right? We're trying to see differences that sometimes are small. So we track for all of our spectroscopy studies, we have the women track their menstrual cycles. And typically, if you're not able to track them, because we don't, so hormonal contraception also impacts the functional connectivity and GABA. I don't know about glutamate. And so we scan medication-free, hormone-free. And so what we do is when the woman, whether she's a postpartum woman or, well, for postpartum women, they're ceasing their menses. But for when we scan around the menstrual cycle, we have the women call us as soon as their first withdrawal bleed, and then we scan within 2 to 6 days of their first menstrual bleed. And so we're getting them in the follicular stage where we know that estrogen and progesterone are still depressed, that they're still really low, because then estradiol is going to start to come up, and then later progesterone is going to come up. And so we're literally like booking patients, like, did your period start? And then we book the scanner. Because we really want to have consistency in our studies and reproducible, you know, rigorous data. Yeah, so I'm trying to get the word out of how important it is. And we're seeing more and more attention to this. We're seeing editorials in journals about the importance of this, and how the imaging field has not regarded sex as a biological variable as well as it needs to. And we need to do this and be examples of how to do this well. So thanks for this question.
Yeah, it is. It's a good question. She had a follow-up question, but since you probably already answered that about women with thyroid problems or hormonal medication might increase anxiety and depression, and would that affect FDA-approved and investigational drug effects?
Yeah, so women in the studies have normal thyroid function, at least for the medication studies. There was a study, a spectroscopy study that was published, I think, just last year on thyroid dysfunction and changes in GABA MRS, and it was megapress GABA. And that showed changes in patients with thyroid dysfunction. I don't know if they had thyroid function panels on them. And when they were, I believe, successfully treated, they reverted back. So we check thyroid function panels in all of our patients before we do any spectroscopy. Typically, we're doing that because we know that first of all, perinatal women are at risk for developing a postpartum thyroiditis or inflammation of the thyroid gland. And so that could affect our spectroscopy and also can induce depressive or anxiety symptoms. And so we want to make sure we're investigating what we think we're investigating. So absolutely. Yeah, there's, normal thyroid function. You have to be, the exact phase of your follicular cycle. You can't have any medications, any hormones, steroids, non-smokers. If we're really, going to get a clear sample, and then we have to deal with the generalizability, of course. But yeah.
Okay, we have another question from Sarah Etimes. Thank you for this great talk. I'm wondering whether you have specific strategies to reduce the risk of postnatal adaptation syndrome in treated patients.
So this is fascinating. I'll start with what doesn't work. So there's data that, so it's associated with third trimester antidepressant use, again, the serotonergic medicines, right? And so there was a thought at one time, that's not true, that if you lowered the dose of the medicine before the women delivered, that potentially could protect the babies from having that postnatal adaptation syndrome. Well, a study came out and showed that the rates did not differ. And so whether you kept the mom on the same dose of the medicine right through delivery, or if you reduced it, it did not reduce the prevalence of postnatal adaptation. What it did do is that it increased the risk of decompensation. So you've lowered the dose of the antidepressant that was working, and now mom's delivered the baby, had another change in her neurocircuit with the reproductive hormone flux, and now she's had increased depressive symptomatology. So we do not recommend lowering the dose in third trimester to prevent this syndrome. So there, we don't right now have any strategies. We always use the lowest effective dose. And that often changes across gestation because the liver metabolism changes across pregnancy. So women's ability to metabolize medications across pregnancy and delivery changes. So they actually, many of them need a dose increase in third trimester. So everybody's nervous about, oh, is this going to, increase the rates of adaptation syndrome, where really just the livers of those women in late gestation are metabolizing the medicine so fast. So we try to use the lowest effective dose. We have great collaboration with our colleagues in obstetrics so that they know women are on the medications. We are in a major academic center, fortunately, so that we have the Children's Hospital, we have the NICUs on standby if they need it. Again, it's supportive therapy. It's not mechanical intubation and invasive measures. But there is this beautiful work happening at the molecular level that we want to understand, well, can we predict which babies will develop it? Because it's three out of 10. And there's some evidence that depending on the genotype of the serotonin transporter protein, the gene, that depending if it's short or long, arms, that is a risk factor. And so, so sometimes moms will deliver one baby and they have it, and the next baby doesn't. And it's fascinating to try to understand what is it about the neonate's handling of serotonin, you know, that might be a risk factor for developing the syndrome. So yeah. So unfortunately, we just use the lowest effective dose, but that's all we can do.
Okay, thank you so much.
Mhm.
I think there's a follow-up question. Are there any genetic predispositions that could affect doses to treat perinatal depression?
Just to make sure I heard you because it cut out. So are there genetic predispositions for?
That could affect doses to treat perinatal depression.
Yes. So so the pharmacokinetics, or the handling of the medications, the metabolism of medications, just change across pregnancy and a healthy pregnancy. But we also know that just all of us, each of us, have different you know, variations of these enzymes, these P450 enzymes that are responsible for metabolizing medications. And so women have different, you know, going into pregnancy, they handle or metabolize the medicines differently from each other, and they may need different dose adjustments because of those differences in metabolism. You know, there are some genetic tests that can look at you know, the different phenotypes for, you know, super metabolizer or slow metabolizer status. We haven't really used those clinically so much, especially in perinatal psychiatry. We're using, you know, really measurement-based care, and we're following the women clinically more frequently, and we're using, you know, validated psychometrics in our clinical interviews to very closely monitor them to know if a dose increase is needed. Knowing that those changes, you know, woman to woman will vary. So as it is that, you know, each of us have different genetic susceptibilities to developing side effects from medications as well. So.
Okay, great, thank you. I guess I have a very last one question. Did the current pandemic affect the incidence of perinatal depression? We know it has increased mood problems severely, right? But does that also go over to the perinatal depression? Did you see any changes, or did the pandemic affect your patients in particular in some way?
So it's an excellent question. What we have seen, I think, more than increased prevalence rates of like clinical perinatal depression, so meeting a criteria of major depression in pregnancy or after delivery, is that many more women are suffering prenatal stress, and so they're reporting very focused stress over either coming down with COVID, because COVID for pregnant women carries a higher morbidity rate in gestation than it does to than to someone without COVID. So it's associated with significant comorbidities, or the baby, you know, getting infected. And so those sort of COVID infection fears that are in gestation are causing much more anxiety, birth, worries about the birth, not having social supports around birth, having traumatic births. And so we focus interventions on really supporting women during the birthing experience, and you know, increased testing across gestation. But we haven't quite yet, though. I mean, we are seeing again a lot of more subclinical stress levels across this period. I think that once the studies are completed, we'll have a better idea if it bumped up kind of the clinical prevalence of perinatal depression. Yeah.
Very interesting. Well, was that, I really want to thank you again for your excellent talk. It was enjoyable.
Great. Thank you so much for the invitation.
Thank you everybody for joining us. And please also check out our webpage for upcoming events in the near future. Thank you everyone, and goodbye.